Good evening and welcome to today's webinar, HFA Policy Priorities and Election Recap. My name is Sandra Wilkes and I'm your moderator for today. Our presenters today are Miriam Goldstein and Mark Hobrach. They are our federal and state gurus here at HFA, and quite honestly, I don't think you'll find two finer policy minds across rare disease. So we're very lucky to have them and their expertise today. We'd love to hear from you throughout the webinar, so please put your questions into the Q&A or the chat box, and we'll take care of those at the end of the webinar. Later this week, we'll be deploying a letter writing campaign to Congress, so we hope that you'll join us with that. You'll hear a lot about that today and the kinds of things that we'll be talking to Congress about. So please be sure to stay tuned to HFA's social media for more information. And again, thank you so much for being with us today. We're really excited to have you because without grassroots advocates, we can't do the work and get to Congress and other decision makers. So with that, I'll turn things over to Miriam and Mark.
Thank you so much, Sandra. Hi, everyone. I'm Miriam Goldstein. I'm Director of Policy at Hemophilia Federation of America. And I'm so glad you joined us this evening. We have a very full agenda tonight. We're going to talk about federal and an election update and federal and state priorities for the coming year. And we're going to put aside some topics that we aren't going to talk about just in the interest of time. So issues about product safety, blood and plasma safety and availability, access to novel products, rare disease councils, all of these are really important things that make up a big part of our work, and they're totally fair game if you have questions to put in the chat. But tonight we're going to really concentrate on COVID, which is such a major part of everyone's lives right now, access to coverage issues, both at because of the ACA litigation, because of what's happening in Medicaid programs, accumulator adjusters, and some other state issues. I always like to start by setting the stage and thinking about what do people with bleeding disorders need from the healthcare system. And you can really boil it down into a couple of words: access. We need access to care and treatments. And in order to pay for those, we need access to coverage. And then we need affordability protections because the cost of bleeding disorders care is high and it continues year after year for life. And that places a special financial burden on our community, and lawmakers need to recognize that and need to address it. This year, everything is more difficult because of COVID, and that's true in the policy space as well as in people's personal lives. So COVID continues to have health impacts, and we very much hope you and your families and all in your social circles are staying well and safe. But COVID also has a huge impact on the economy, and because it impacts the economy, it has an effect on state and local government budgets. The 2020 elections, unbelievably, are still playing out, and control of the Senate, which is not yet decided, is going to have an impact on how much of President-elect Biden's agenda moves forward. And then there's the question about litigation in the Supreme Court. So let's start with some of the COVID-related initiatives, and we'll go through those pretty quickly. As I said, it's obviously dominated the agenda since COVID sprang on the scene in the winter. And so some of the activities that we have done in response are obviously seeking to make sure as many people retain coverage as possible despite job loss, and so expanding access to health coverage, whether that's via Medicaid, via the marketplace, via COBRA. We've been supporting paid and protected sick and family leave. That's important to people with bleeding disorders at any time, but it's important to everyone across the country in this time of coping with a pandemic. We helped lead a letter for bleeding disorders organizations asking Congress, when it was looking into relief, like the Paycheck Protection Program, for businesses to say, hey, nonprofit organizations need to be considered too as you think about how to keep businesses and employers in operation. We've engaged in advocacy around crisis standards of care policies, making sure that the states don't adopt triage policies and crisis care policies that discriminate against people with disabilities and health conditions. And advocacy continues to try and get Congress to pass a desperately needed fifth COVID relief package with further assistance to families and further boost to federal spending, further expansion of health coverage, and promoting plasma collection, which is important to our community and the individuals who still use plasma-derived products. Unfortunately, that relief package has been stalled, but it remains a priority, and we'll talk a little bit more about that in the election update. And then we've had outreach initiatives to try and keep the community informed and aware of these activities. So creating a comprehensive COVID hub on the website. We were very happy to collaborate with NHF on a resource for people who might be experiencing insurance loss because they experienced job loss, and that is available on both organizations' website. And researching and publishing guidance, and I have to give full credit to my colleague Mark, who will be speaking to you soon, about an issue that ended up being much bigger than we thought, about how to maintain coverage for community members who are covered by Medicaid by virtue of the fact that they receive SSI disability payments. So access to coverage, as we said, has obviously become so much more pressing across the country because of the pandemic. Access to coverage is non-negotiable for our community all the time, but it has become a major issue across the country. And it has done so at a crucial juncture as litigation has gone forward now in the Supreme Court in a case that seeks to overturn the Affordable Care Act. This case has been going on for 2 years, and it's a little convoluted. Its origins lie in the fact that the Supreme Court has already considered the constitutionality of the Affordable Care Act twice before and has upheld it and the individual mandate portion of the Affordable Care Act as an exercise of Congress's taxing power. But Congress in 2017 passed a tax bill that got rid of the dollar penalty for failing to carry insurance as required by the individual mandate. And so at the time, 20 states looked at that and said, with the dollar penalty gone, how is this a tax anymore? And they sued to say now the individual mandate is unconstitutional, and with the mandate gone, the entire ACA should be overturned. I have to tell you that legal experts, and this includes lawyers who are on the other side of some of those earlier ACA cases, really don't think very much of the legal theories behind this case. And yet, having said that, 2 courts so far have ruled in favor of the challengers. So it is of concern. I should also say that HFA and NHF, together with 18 other patient and health advocates, are on record in the Supreme Court case. We joined in what's called an amicus brief, a friend of the court brief, to explain, to lay out for the court why the Affordable Care Act and its patient protections are important to people with bleeding disorders. And this is why they're important. The ACA just marked its 10th anniversary since its enactment. And over that time, it's become almost taken for granted. It is now so much part of the bedrock of the American health insurance system that people kind of forget what things were like before the ACA and the protections that it brings. So pre-existing conditions is one that most people would be able to identify as something protected by the ACA. But Medicaid expansion, extending coverage to low-income adults regardless of disability is something that the ACA brought. An end to lifetime and annual caps on benefits, which were major issues for this community, also traces back to the ACA. Essential health benefits, the fact that your plan has to cover what you need to stay healthy, part of the ACA. Marketplaces to buy coverage if you don't have coverage from work, part of the ACA. So there's a lot at stake in the litigation. The Supreme Court heard oral argument in the case just last week. And in our COVID world where everything was virtual, you could listen in on C-SPAN, and I did, and some of my colleagues did. And while it is a dangerous thing to try and predict how the court will rule based on comments that we make during oral argument, we are cautiously optimistic. And it turns out there are several different pathways that the court can take to arrive at the endpoint that we would like, which is that the ACA survives. And so some of these are pathways that justices could take, even if they are not friends to the ACA in general. So they could find that the challengers lack standing to bring the lawsuit, that in fact they're not injured by the continuation of the ACA or by an individual mandate that no longer has a penalty. They could find that the mandate's still constitutional, even though there's no dollar penalty associated with it anymore, because either it still is a tax because Congress could always restore that dollar penalty, and so it's just temporarily not collecting funds, or looking at what Congress intended in 2017 when it passed the tax cuts law. Did it really intend to upend the entire ACA? Probably not, because that very year they had tried 6 other times to repeal and replace the ACA and had failed. So it seems pretty far-fetched to say that they were secretly and surreptitiously repealing the ACA by zeroing out the mandate. Or a justice could say, hey, I think the mandate is now unconstitutional, but you know what? It's severable from the rest of the law. So the mandate gets struck down, but the rest of the law stands. Like I said, we can't say with certainty how the case is going to come out. We really can't predict, and the court will not rule until well into 2021. They don't have a timeline. They can rule whenever they like, but no one expects to get a decision from the Supreme Court before 2021. A key thing to know is that for now, no matter what happens, for now the ACA remains the law of the land. Those lower court decisions against the ACA have been stayed, and the ACA patient protections remain in place. The marketplaces are opening, the Medicaid expansion is still in place. And this is really key to remember because we are right now in open enrollment. And so a message for all of us, if we are with a bleeding disorders organization or talking to friends, is the ACA protections are still in place. It's open enrollment. Use your opportunity to get the coverage you need. Plans are affordable because most people who buy ACA marketplace plans are eligible for financial help. And anyone who experienced job loss in 2020 should at least look at their options through the ACA. So the litigation is not the only one of the access to coverage barriers that we've been concerned about over the past year and for the coming months. One thing that has kept us very busy is engaging with Medicaid work and reporting requirements that have been proposed by about a dozen states and approved by the Federal Centers for Medicare and Medicaid Services, the federal agency that oversees the Medicaid program. In coalition with other patient groups, HFA has opposed these eligibility restrictions and continues to oppose them. And that is because they create red tape and hurdles to stay covered by Medicaid. In Arkansas, the state that went furthest along the road of implementing their work and reporting requirements, 18,000 people lost coverage in just the 4 months period that their requirements were in effect. Now, a federal court has actually overturned those work and reporting requirements in 4 states. And that ruling, unlike the ACA ruling, is in effect. So those 4 states have been enjoined from enforcing their work and reporting requirements. And basically all the states have at least hit pause on their work and reporting requirements, either because they're waiting to see what happens with the litigation, or because they are responding to the circumstances we find ourselves in with COVID. And one of the federal acts that was passed in response to COVID early this spring gave enhanced Medicaid funding to states. It gave a higher federal matching rate, but in exchange, states had to agree not to kick people off their Medicaid rolls. And so whether it's out of fear of litigation risks or in compliance with those maintenance of effort requirements, states have generally paused their work and reporting requirements for now. Another Medicaid initiative that causes us concern and that we continue to oppose is the idea of block grants. So CMS, that federal agency that oversees Medicaid, had issued guidance inviting states to apply for block grants to fund their Medicaid program rather than the open-ended federal matching system that has traditionally been in place for the Medicaid program, where as state spending goes up, federal contribution toward the state program also goes up. We are concerned about block grants because they are a way to cut and cap Medicaid spending and really take away flexibility from the program to respond to situations like a pandemic or like a natural disaster, like as we find ourselves in now. Also, in the block grant requests that have come in so far, the states typically ask for what they call flexibility. And so in the case of Tennessee, they asked in return for the block grant if they could have greater leeway to basically exclude coverage of certain drugs. The Medicaid program generally has to cover all approved prescription drugs. And so we see that as a threat and as something that we would oppose. And again, while the guidance is in place, there are not currently any block grants in effect for Medicaid right now. So between COVID, between the litigation, between the election and the fact that healthcare has been a prominent issue for many voters over several election cycles, healthcare was certainly front and center this fall. And so as we approach the election, HFA and NHF and 31 other patient groups wanted to go on record with what we called a 100 days agenda. This was shared with both campaigns. And it was a recognition that the ACA is really important. It needs to be preserved, but it is not perfect. It needs to be built on because we have so much more to do in terms of achieving health equity, in terms of achieving broader coverage, dealing with coverage gaps, and working towards more affordable coverage and more affordable care. Recognizing that people still, even if they have access to coverage, may have trouble affording care. And so the patient groups agreed on this consensus agenda, which is a very long document. It's available on the web, and we can throw a link up into the chat for anyone who wants to read it. but it calls on Congress to take a really patient-centric view, to do things to enhance affordability, like enhancing subsidies for health insurance coverage on the marketplaces, addressing the family glitch and the subsidy cliff and other quirks in the law that make care and coverage expensive for families. It calls on the incoming administration to roll back some of the harmful policies of the last couple of years, like expanding short-term plans and association health plans and other substandard products that might look like insurance but leave people unprotected. It calls for undoing those work and reporting requirements in the Medicaid program and offering enhanced federal funding as a carrot to encourage the 12 states that have not so far expanded Medicaid to take up Medicaid expansion. So as I said, the ACA is not perfect, and there's more to be done. Even people who have insurance can still face barriers to care. And Mark's going to talk a lot of. We have a lot of our state level portfolio of policy priorities focuses on some of these barriers to care, but I'm going to touch on one of them in this federal portion, and that is accumulator adjusters. So a mouthful of a name, but unfortunately we've all become familiar with over the last couple of years. Accumulator adjusters is the health insurer practice, a cost control attempt that says, yes, you as a patient, you can continue using your manufacturer copay assistance programs to help cover your medication copays and coinsurance. But you know what, we're not going to count that towards your overall out-of-pocket, your overall deductibles and cost-sharing obligations. So all of will draw down the full value of that copay assistance. And then in month 3 or month 4, when it's all depleted, you go to refill your prescription, we are going to come after you and ask you for potentially thousands of dollars in copay. That is untenable for many and makes it hard or impossible for people to keep getting their medication, which is so essential to their health. So every year, the federal government issues a rule. It's that agency, CMS again, that issues a rule governing health plans for the coming year. And for a couple of years, the issue of accumulator adjusters has come up in that rule. In 2019, we were actually encouraged. We made the case against accumulator adjusters, and the first version of the rule that came out said, we hear you, we understand the importance of copay assistance, and you know what, if you are using a medication for which there's no generic equivalent and you get copay assistance, the insurer can't apply this accumulator adjuster treatment to your copay assistance. Unfortunately, almost before the ink was dry, the federal government reversed that position on the basis of some pretty arcane technical tax law considerations. And so the upshot is that health plans can use accumulators in 2020, and the rule for next year says that health plans can use accumulators next year also. One notable feature is that the rule, and the federal rule, does create an exception. It says if you live in a state that provides state law protections against accumulator adjusters, those state law protections will take effect. Normally, federal law would preempt state law, but with respect to protective state law about accumulators, the protective state law governs. That is somewhat limited protection because if you get your insurance through work and you're in a self-funded plan that is regulated under ERISA, state law doesn't apply to you. So what does that mean? It means that our next steps on the accumulator adjusters will take place on several different levels. We will once again make the case against accumulators when this year's iteration of the rule comes up. This will be the rule for governing health plans in 2022. We are working with member orgs to pass state level protections in additional states. 5 states so far in Puerto Rico have passed state law protections against accumulator adjusters, and we have about a dozen states that either started down the road to enact these kinds of protections and then got derailed by COVID, or will take them up again in the 2021 legislative session. And so since there is that carve out for state law, we decided it makes a lot of sense to try and get state law protections. And we're supporting a federal bill, HR 7647, which kind of takes a hook into COVID and says, look, people right now, because of COVID, are experiencing a lot of financial distress. We cannot add to that burden by depriving them of the value of copay assistance. And so let's pass legislation to pause the federal rule, to say no accumulators through the COVID pandemic and for a year afterwards. And those are really our the 2 big issues for this week's virtual Hill Day. We are going to be talking about access and reminding lawmakers about the importance of access to coverage and to quality, affordable coverage. We're reminding them that this is important for us as a community all the time. It's important for everyone given COVID, and the issues are thrown into highlight by the Supreme Court case over the ACA. And we're talking about affordability. We're going to be asking our representatives to co-sponsor the federal bill addressing accumulator adjusters. And we're going to educate our senators about the issue and see if we can get any of them interested in sponsoring companion legislation in the Senate. And so for that, I am going to turn things over to Mark, who is going to take you through some of the state policy priorities.
Sure, thank you, Miriam. I just wanted to spend a couple of minutes before we get into the election overview, talking about some of the state priorities. And really the main thing that I want to emphasize is obviously the federal elections have been a very understandable focus and gained quite a bit of attention, but it's really at the state level where we have seen most of the action for 2020. And as long as the government remains divided in Congress, it probably will largely remain that way in 2021. So as a result of that, we've worked very closely with the HFA member organizations to support both state laws and regulations that would promote access to affordable care. As Maria mentioned, preventing the harmful effects of copay accumulators as one of the top priorities. And that's especially true because it's an issue where we've seen very broad bipartisan support. And we've already had success, as she noted, in 5 states that are very so-called red states, very conservative states, and also very blue states. So it's an issue where we expect that we can have some success again this year. We have about a dozen states that are expected to introduce new bills, especially those that had their legislative action interrupted last spring by COVID-19. And we expect a number of those will likely pass, again, because it's an issue that the harm to consumers is so clear that there is not a lot of objections to it. Other areas where bipartisan support has and should continue to lead to substantial progress include things like capping the out-of-pocket costs for prescription drugs. We've seen about 20 states, maybe a few more, that have already passed those types of laws. Step therapy protections we continue to see despite COVID-19. There were 3 states that were able to pass that this year, and there's nearly 30 now in total. And also we're continuing to focus on reinsurance programs. These are something where insurers can get additional reimbursement whenever they incur exceptionally high cost claims. We've had 15 states already get federal approval for waivers to operate their own programs, and the results have been very dramatic in some cases, as much as 20 to 25% reductions in premiums in the individual market. Next slide, please. Next slide, I mentioned this one. Now, one thing I should mention on step therapy. The 3 states are South Dakota, Louisiana, and North Carolina. We do expect some other states to go forward. But again, this is an issue because there's pretty good bipartisan support for it. We don't expect a lot of pushback. Now, next slide, please. Expanding, I think we skipped one slide. Yep, expanding Medicaid is one area where we do continue to expect a lot of pushback, and that's it continues to be a priority of ours. There's only a dozen states left that are still opting out, that are still fighting it. Miriam mentioned the ballot initiatives that I'll talk about a little bit in a few slides that added 2 states this year, Missouri and Oklahoma. But it's still a very politically polarizing issue, so we don't have that bipartisan support at all. And it's an issue that we really continue to have to fight in a number of state houses. The skinny or short-term health plans is another issue where there's not that bipartisan support that we like to see. We expect to see significant pushback, especially in conservative states where these plans have become very popular, even though many consumers are not aware of the limitations or deficiencies about those plans. So it's something where we continue to push for new limits, or at least to have greater transparency to inform consumers about the problems with them. And that's it for my part here. We'll switch back to Miriam for the federal overview.
Mark. As everyone knows, I'm sure, the presidential election results are in, even if the transition is being delayed. The US Senate results, however, are still pending, and there's a lot riding on this. So right now there are 48 Democrats and 50 Republicans, and in a very unusual set of circumstances, 2 Senate seats are up in Georgia at the same time. And because Georgia requires the winners of an election to get at least 50% plus 1 of the vote, and neither candidate did so, both Senate races in Georgia will go to a runoff on January 5th. And this means the control of the Senate is at stake. If the races were both to go to the Democrats, it would be 50-50, and Vice President Kamala Harris would have the deciding vote. If the runoffs go to the incumbents, or both Republicans, then we would have a 52-48 split in the Senate, and Senate Majority Leader McConnell would remain as Majority Leader. In the House remains under Democratic control. They lost some seats, so the margin is narrower. And so what does all this mean for the prospects of policymaking in the coming year? The top priority is going to be combating COVID-19. It just has to be. Obviously, there's a need for a response both to the virus itself, and that is as a public health measure. So trying to get control of the virus, and thankfully it appears trying to figure out distribution of now 2 promising vaccine candidates and maybe more. And then there will need to be a response to all the ancillary impact of COVID on the economy and society. But as I said, the COVID relief package has been held up. The House passed a package back in May that was $3.5 trillion. The Senate is not remotely interested in passing anything close to that size. And so they have been in the standoff ever since. So the House bill would have included aid to state and local governments. It would have included unemployment insurance, would have included an additional boost for Medicaid spending. It included language about encouraging plasma donation and collection, and a lot more. The Senate bill was much narrower, and unfortunately the sides are still in that same standoff. One thing to note is that the HHS has declared a public health emergency. I think they have extended that twice since the first declaration. And there's a lot that hinges on that declaration of a public health emergency. A lot of flexibility for the Medicaid and Medicare programs. Also that Medicaid maintenance of effort requirement. So the current public health emergency expires on Inauguration Day. And so it's not clear whether the present administration will act to extend that before Inauguration Day, or if that will have to be, frankly, one of the first actions of the incoming administration. And then there's all the other health policy priorities, that ambitious agenda that was laid out in the 100 Days agenda, and the agenda that President-elect Biden campaigned on. And it seems like parts of that agenda will have a hard time going forward, either if the Senate and the House remain in different parties, or frankly, with very narrow majorities in both houses, if the Democrats in Georgia win the runoff. But there are things that a Biden administration can do even without legislation. So they will certainly be trying to work with Congress and trying to see what can be done in a bipartisan manner, or in this situation of narrow margins. But they also have regulatory levers that they can use to, again, try to encourage those remaining non-expansion states to expand Medicaid. They can reverse some of those, the administrative positions of the past 30 years on Medicaid work requirement and reporting requirements. Not clear if they can reverse some of these things right away, or if they have to go through a full notice and comment regulatory procedure, which would take a number of months. They can restore funding for healthcare.gov, the outreach, the ACA marketplaces, and there's a lot of speculation that a Biden administration would act quickly to reopen the open enrollment period, which for many states will have closed on December 15th. And then again, a long-term project of undoing some of the Trump administration regulations on short-term plans, on narrowing the scope of non-discrimination protection, on the rules governing how states can apply to change their marketplaces. And Mark, I think this is you.
Okay, well, at the state level, 2020 was a particularly critical year. And that's because with the census, it was the year that decides which party is going to control the redistricting process over the next decade. And obviously that has a lot to do with which party can remain in power. So Democrats had expected to really make a number of huge gains, and that was solely based on how well they did in 2018 in the midterms. When they were able to make up a good chunk of the record number of seats that they had lost during the Obama administration. There were two consecutive elections, actually three, 2012, 2014, 2016, where they lost quite a few seats at the state level that really hurt a number of initiatives that we wanted to pursue. Those were largely made up. They expected to have even bigger gains this year. There were a number of states that they had even targeted and had high hopes for. Certainly Texas was one of them. They expected to make up the 7 seats they needed for the Texas House. They expected to get both chambers in Arizona, and the Minnesota Senate, North Carolina Senate, Pennsylvania Senate were other big targets of theirs. However, in the end, apart from the top of the ticket, it was actually a very good night for Republican legislators at the state level. They were not only able to fight back any Democratic advances, but they gained a number of seats, and they were the only party to pick up chambers. They picked up both the New Hampshire House and Senate. They are projected to win the Alaska House, even though there's still some doubt about the one House race that would move it from a power sharing, essentially a tie, into Republican control. But it really wasn't the type of change that we're used to seeing in state elections. Typically, we see as many as 10 to 12 chambers switch parties in an election year. This was the first time since 1946 that there were fewer than 5 that actually switched control. Next slide, please. Now, overall, the GOP still controls 62 legislative chambers. It's only up 1 net gain from last year. It's down from the high that they had 4 years ago of 66, and the Democrats control 37. And the map that you can see there shows where they are. And for the most part, it aligns with how the top of the ticket turned out. The GOP still controls both the House and Senate for 29 states. So still a solid majority over the Democrats. And believe it or not, there is still only 1 legislature that is split, and that is in Minnesota. That is a very unusual occurrence, but that's stayed that way now for 2 election cycles. There are 38 states where one party or another has a trifecta. That's where the same party that controls the House and the Senate also controls the governorship. And as you can see, the GOP gained a couple of those, so they're up to 24 now, with presumably Alaska, as well as Montana, where they won the governorship, and New Hampshire, where they had a Republican governor but picked up both chambers. And by contrast, the Democrats only have 15. But one of the most important criteria in terms of us trying to move legislation is who holds a supermajority. And as you can see, the Republicans really cleaned up there in past years and were able to hold on to most of their all of their chambers, and gained an additional one with the win in the Montana House. So they have a supermajority in 31 chambers compared to only 20 for the Democrats, who, despite picking up some, they also lost a few. And the GOP was able to make advances in states like Florida, where they had been expected to lose seats. They instead picked up 5 seats in the House, so they have near a supermajority there, just like they did several cycles ago. And also were able to prevent Democrats from digging into their huge majorities in North Carolina and Wisconsin, 2 states that are critical for the Medicaid expansion, as we'll talk about in a second. Next slide, please. Now, at the governor level, we didn't see a whole lot of change. There were only 11 races overall. All of the incumbents won, same thing that we saw with the attorney generals. There were 2 open seats. Montana, as I mentioned before, the GOP was able to flip a seat, and they held their seat in Utah. So they had a net gain of 1. They now have 27 of the governorships compared to 23. And this is obviously a huge issue, because governors wield a tremendous amount of influence over health reform bills, not just because they can veto or sign bills. They have the ability, obviously, to appoint agency directors for Department of Health or Medicaid, but also in most states, they appoint the state insurance commissioners. In several states, we've also seen them be able to expand Medicaid administratively through executive order over the objections of their state legislatures. And as I mentioned, we saw the same in action with the attorney generals. There was not a lot of change there. They held the 2 open seats. And again, in past years, like in 2018, that's been a big deal when we've seen a lot of change because they can challenge certain health reform laws or defend certain health reform laws that we support. So it's something that we generally see more change, but didn't see any this year. And another issue where we did not see a whole lot of activity was in terms of ballot initiatives. Last year, we saw a high of 60, where these were citizen initiatives to put a referendum on the ballot to basically circumvent legislatures that were opposing. In our case, Medicaid expansion is the #1 issue where we see legislatures voters be able to go forward despite legislative opposition. The two big victories that I mentioned we saw in Missouri and Oklahoma were actually moved to the primary elections this year. That was in an effort to, because there would be lower turnout in a primary election, lessen the chances for them to survive. And indeed, it took them from a very wide margin that was expected to pass down to very narrow margins. I believe the one in Oklahoma passed by only about 0.5%. So of the 37, and again, I should mention the obvious reason that we've had so few this year was the coronavirus. That makes it more difficult to gather signatures, either in person or in public. And as a result of that, we saw only 37 and about 25 of those appear to have passed. The one that was most significant for us was in Colorado, where for the first time we saw a ballot measure pass that actually created a family and medical leave insurance program. One of the other big developments was 3 states had tried to make citizens initiatives more difficult. And that was largely because of the success in passing Medicaid expansion. Those citizens initiatives are 6 for 6. They have not been defeated yet. So we've had 6 states expand Medicaid that way. And we saw 3 states try to combat that, Arkansas, Florida, and North Dakota, by passing requirements that would make it more difficult even to put the citizen initiative on the ballot. In Florida, that was done by trying to pass a requirement that said that you had to have an citizen initiative pass in 2 consecutive elections, which is a very difficult hurdle in this state because it's one of the few that requires a 60% majority to pass an initiative. So that would make it highly unlikely to do so 2 elections in a row. But again, all 3 of those states, they were not successful. So that has huge ramifications. Next slide, please. For Medicaid expansion, there are 2 huge states that have still not expanded Medicaid under the Affordable Care Act. They are Florida and Texas. Because Democrats were not able to make any gains in those state houses, there's not likely to be any movement on it next year. Both are likely to require citizen initiatives in 2022. Fortunately, in the case of Florida, it won't require 2 consecutive elections to pass. One other thing that we'll see as a result of the state elections is with gaining the trifecta in New Hampshire and Montana, and presumably also in Alaska, we could see more limits placed on the Medicaid expansions that are already in effect in those states. Obviously, things like work reporting requirements and higher premiums would no longer be federally approved by CMS with the change in presidential administrations. But at the state level, we could expect to see them do more things to limit their expansions in those states. We also do expect more, like I mentioned, prohibitions being pursued for both red and blue states for accumulators. But the states that have retained GOP control, you're more likely to see the weaker version of that legislation, which, as Murray mentioned, would prohibit accumulators only when there was no generic alternative. For us, that's not as big a deal, obviously, but the preferred bill would be one that's a across-the-board prohibition like we saw in states like Illinois and Virginia. We are not likely to see, I'm sorry. We are not likely to see more additional transitions to state ACA marketplaces, just because there wasn't a change in governorships. But that's something that we have seen several for this year, and something we still strongly support, because if a state has control of the marketplace, they can do more consumer-friendly changes, most importantly, extending the enrollment deadline beyond December 15th. And other changes that we'd like to see, like creating a special enrollment period, like many states did for the coronavirus pandemic. There's other reforms that we'll see in the more states that have remained blue, things that would strengthen or expand the ACA, like the public option we saw in Colorado and Washington, the enhanced subsidies that we've seen in states like California and New Jersey. But again, because there was not a lot of movement among states, we don't expect to see any change to the states pursuing the Supreme Court challenge or other types of initiatives like that. So that's all I have here, and we'll move to any questions.
All right. So I warned everyone at the outset that we have a fabulous policy team here at HFA, and I failed to introduce Kimberly. So Kimberly Ramser is also a part of our team and covers state issues, as well as handles a lot of our advocacy efforts with our young adults. But I'm going to put Kimberly on the spot, kind of put her on the hot seat right out of the gate here, Kimberly, with some of these questions. And I was wondering if you could answer one about the seats that were lost in the House. Were any of those seats, congressional seats, champions for the bleeding disorders community?
Hi, so thank you for that question. As far as champions for the bleeding disorders community, it's kind of hard to say. I would say that we lost some individuals that supported a lot of the things that we advocate for. So that is a great loss. But I will say that as a nonprofit, we are nonpartisan. So that anytime you get anyone in a seat, it is an opportunity to establish a new relationship, no matter that party affiliation. And so it's a great time to reach out to any newcomers to establish a relationship and let them know more about bleeding disorders and advocate for things that are a priority for us.
Thank you. Thanks for.
I can add at the state level.
Yeah, please, Mark.
At the state level, we're not aware of yet any of the people that we expected to be sponsors for our bills next year, whether it's accumulators or step therapy or other issues. That have lost their races yet. I know there was one in Oregon that was in a very tight race, but certainly the main sponsors that we were targeting for next year so far appear to have retained their seats.
Thank you. Miriam, I'll come to you for this next question. What do you think is the greatest impact that COVID is having or will have on laws that affect our community? And how long do you think that we'll see that effect? Is it 6 months, a year to 3 years out post-COVID? What's in your crystal ball?
It's hard to separate it out from the impact on the country as a whole. I think the impact is so far-reaching that, but I will say that one of the things that I worry about is the stress on state budgets and state Medicaid programs. And without additional federal money for those programs, I fear that states have to balance their budgets. They can't do deficit spending the way the federal government can. And so the prospect of where states would turn to make cuts in their Medicaid programs is something that, that is of concern. Mark, do you have others?
No, that's it.
Well, Mark, while I've got you, we answered this in the chat, but we'll make sure we answer it live too. Any word on when Senator Harris's seat will be filled in California?
A lot of that depends on when she formally resigns, and that likely would not take place until after election is certified and the electors, all the formalities are done. It would occur sometime before they're sworn in January. And then presumably the governor, as Kimberly mentioned, has somebody lined up already and the announcement would come very quickly. But she would still have to formally step down before they probably announce that.
Awesome. Thank you. Miriam, I'll come to you for this question. Why is CMS offering block grants instead of the normal matching? Is there an upside to them at all?
This is an ideological difference. I would not expect a Biden administration to go forward with block grants. And I think the argument for block grants, as I've heard it put forward by, for example, Senator Cassidy of Louisiana, is the federal government is writing a blank check to the states with the matching funding. And why not encourage states to experiment? This whole idea of the states as laboratories for experimentation and see if they can find more efficient and more cost-effective ways of delivering care. And so if the exchange, or the idea behind the exchange, is block grant. In exchange, the state gets more flexibility to run its own Medicaid program and deviate from some of the requirements that otherwise federal law would require, and then potentially keep the shared savings. The problem with block grants have been tried in the food stamp and TANF programs, right? Is that right, Mark? And the problem is that states don't always use the money in the block grant the way that it's supposed to be used. So, so really the concern is putting states in a bind where they cannot respond to an increased need for coverage because of an economic downturn, because of a pandemic, because of natural disaster, and where that increased flexibility for the state ends up meaning reductions in care for the people who are supposed to be served by the program.
Yeah, just to follow up on that, the biggest problem is that with the matching rates that they have now, if your Medicaid enrollment goes up dramatically, like it has during the pandemic, your federal reimbursement goes up. With a block grant, that's not the case. You get a lump sum amount, and if your enrollment goes up dramatically, your federal reimbursement does not go up, and you have to start making dramatic cuts. So it's certainly something that we have expressed concern about in comment letters to Tennessee and the other states that have proposed this.
Great. And I think we have time for a final question. And I'm just going to throw it out there. Whoever wants to answer, please do. I'll give you a hint tomorrow night. But how do patients that are born with the DNA defects not qualify for medical help? Isn't this discrimination? And is there a new way to talk to both parties about this? How do we get them to look into gene therapy in the future?
Well, Sanja gave the hint, and the hint is, please talk to your lawmakers and let them know, let them know your story and let them know what you are looking for. Yeah, it's, being born with a bleeding disorder is sort of enough in and of itself without having to be, a constant worry about, can I access the care I need? Do I have the coverage I need to afford that care, to purchase that care? Can I afford that care? Make your voice heard. Contact your lawmakers, and please, we've made it easy. You can use the tool that we sent out, and that's available on social media. That will, if you enter your address, it will immediately connect you with your lawmakers. There's a pre-populated message. Feel free to send it as is or edit it and put in, what you want your lawmakers to know. What are you looking for them to do?
And I'll just add, tomorrow night we have our congressional reception, and during that time we will be honoring a representative who is looking at personalized medicine and has began a personalized medicine caucus in Congress this year. And so I think that sort of thing is what's helping us to be able to raise our voices and raise awareness about these issues. So we do hope you'll join us tomorrow night for that congressional reception. The registration link is very likely in the same email that you received for this webinar, but it certainly is also available on our website and on our social media pages. But thank you so much to Miriam, Mark, and Kimberly for their expertise. Thank you for joining us tonight. We hope that you'll take 5 minutes to take part in our virtual Hill Day this week and join us tomorrow night for our congressional reception. Have a great night and be safe and healthy.